So I think it's important to give a little introduction as to how I got to this place to start using a platelet fiber matrix. So when you're doing biologics, I kind of put it in a little bit of a Punnett square. So you have something that you can use superficial, something you can use deep, something that you can use that's biologically active, and something that's not biologically active. What I used to use was umbilical cord. An umbilical cord was one of my favorite things to use because it had tensile strength. There was a certain amount of thickness. Now, sizes were a little bit of a problem because the good Lord only makes it in one size. But you also had biologically active, precursor cells that were highly filled with growth factors, and the wounds, when you would use this, they were just fantastic. Now, unfortunately, due to regulatory issues, that's not available anymore. So this happened during COVID, and so when I was done, I still needed a highly active biological graft that could be versatile. Maybe it doesn't have the same kind of tensile strength, but it was versatile and was easy to get. And many years earlier, I did some work, actually, even when I was a resident, I did some work on PRP and using them for wounds, but it's not a very stable unit, and we'll go through why. And so I did a little bit of research and started working on fibrin matrix platelet grafts, which hold the growth factors inside and elute at a different level than just when you put in a liquid, it just kind of goes everywhere. So the reason that I had looked for something like this or got myself involved in this is because I had a lack of something else. And then was pleasantly surprised at some of the data that came out, and I published on this a couple months ago, and so we'll go through some of the data on that. Okay, so outline, what's PRP, how do you make it, how is platelet-rich fibrin matrix, PRFM, different from PRP, and then what's the data on using this for diabetic foot. So we start with whole blood, which is more than half plasma, some white cells and platelets, and red cells. Platelets are small granulating bodies. They live for about a week. They're produced in the bone marrow, stored in the spleen, and are involved in the initial parts of wound healing. In the plasma itself, that's the fluid part of the blood that contains proteins, antibodies, clotting factors, ions, and in order to be able to get this, you have to add an anticoagulant to harvest the plasma. Platelets, which is what we're really interested in, have a hemostatic effect, right? You cut yourself, you get a hemostatic effect. It acts as a scaffold for other cells to glue themselves onto. There are growth factors there, and there's also sites for stem cells to bind to it. There really is no scientific, or let's call it dictionary version of what PRP is, right? But basically, you'll take a lot of platelets and you concentrate them in a smaller volume of plasma. Somewhere between 3 and 5 times the amount of platelets that are usually in that same amount of plasma, and that's how you kind of spin it down and then concentrate it. Some people will tell you, oh, you need 3 times, 5 times, 5.5 times, that's why it's better. This one has white cells, this one doesn't have white cells. There really is no consensus on it. Now, when you look at a regular blood smear, you'll see a couple of little platelets here and there. When you have a PRP smear, they're all over the place. When you have a resting platelet, so under electron microscopy, you'll see this. They look like small discs, but when they're activated, they get all funky. The more platelets you have, this kind of sounds logical, right? The more platelets you have, the more growth factors you have. So human platelet-derived growth factor, the version AB. So the more platelets you have, the more growth factors you have, right? There is a commercially available version of platelet-derived growth factor that comes in a tube that rhymes with Schmagranix. And that's a different isoenzyme. That's the BB isoenzyme. This is the one that we have in our body. Now, growth factors do a couple of things for us. Like, why do we want growth factors, right? So growth factors are your friends in the bar that somehow know how to call other people and make a party, right? You're like hanging out by yourself, you got your friend growth factor, comes around, and basically everybody comes to the party. So that's the chemotaxis. Right? And then there are migrating cells that come to that area. They also then start to make more of themselves, and then they turn on the platelets for the platelets to be able to do their job. There are lots of growth factors. Here are some of the growth factors: PDGF, platelet-derived growth factor, TGF-beta, and VEGF. These are all three of the ones which are, I would say, more popular that are in them. When you have PRP, you have more of these growth factors, 5 times the amount of PDGF, about 3.5 times of TGF-beta, and about 6 times in VEGF. How do you make PRP? So the first thing is you need to stop the blood from clotting. So you need to stop whole blood from kind of becoming clotted blood. And the way to do that is by binding calcium with citrate. Then you centrifuge it out to be able to separate it out. There are lots of different systems to be able to separate them out. And then the last thing is you need to make sure that the platelets don't get activated, right? When you activate the platelets, it secretes all its growth factors, right? About 100% of growth factors are secreted within the first hour of activation. And you can do this by adding thrombin to it, or you have collagen, right? So injured collagen I mean, if you think about from a sports medicine perspective, that's what you're doing, right? When you put a needle in, you're injuring it, and then you injured collagen, and then you inject the PRP, and the PRP now knows where to go. Questionable whether that's enough and whether you really have to injure the collagen in order to be able to do that, and you can do that with other tools. Why don't you use PRP in wounds? So like, that sounds great. It's got all the growth factors. We want that. We've just talked about something that rhymes with schmagranix, right? We do that there, right? So like, why wouldn't we want to put PRP in wounds? It sounds logical, right? So the first things first is it's a liquid, right? You put it into something, it kind of goes all over the place and you can't really contain it. Secondly, in order to be able to make PRP, usually thrombin is added to it. When thrombin is added to it, all the growth factors, as we said before, all the growth factors kind of get released, right? And then the other thing that happens is when you do release them, there are all these sites that are on platelets and on tissue. And when you do that, they get thrust in there, and all those sites get kind of filled, right? So there's 100 seats, and 100 seats are filled, and now you have all this extra stuff which is hanging around, which does nothing and actually can become detrimental because it can downregulate things. The idea of doing a fibrin matrix here is that it acts as a scaffold, so it holds everything in place, right? There's no fibrin that's attached to it, so there's a natural clot that forms, and it doesn't allow all the growth factors to be released at the same time. And as it starts to repair itself, it starts to recruit other cells like fibroblasts, and then collagen starts to be formed around it. The other thing that platelet-rich fibrin matrix does is it has earlier cells, so it has mesenchymal cells that are inside that helps regenerate that tissue as well. How do you make it? So it's basically the same thing as how you make PRP, just you add other items to it in order to be able to make a fibrin matrix. Okay, so I want to just show you pictures. It's a little easier to see. So here's what a kit looks like. You do the same thing. You draw it out, and then you take 2 of these tubes, and then you remove out the PRP from it. You put into another tube here, and then spin it down at a much faster rate for a much longer period of time. What that does is it creates an actual graft. Like this, it's suturable. That's there. And it takes on the shape of the vial. So the vial, depending on the size of the vial, that's how big your clot is going to go ahead and be. And this is what it looks like when you're done. So the first spin is a 6-minute spin to get your PRP. You take out the PRP, you put it into another vial, and then you spin it down, and then it makes a clot. Excuse me, not a clot. The clot's a completely different thing. It makes a matrix. And this matrix is suturable. So again, same thing as in just other words. So there were some in vitro studies to say, okay, this is very good. So how is this different than PRP? So there were a bunch of studies that were done to see, is there sustained growth factors over time? Because we don't want all the growth factors to be released immediately. Well, we did a washout study, and then the washout study, it shows you that the platelets and the growth factors, remain within the platelets after a week. Same thing here is that it actually stabilizes over time as well. So in summary, right, the platelets and growth factors in the matrix, they're functionally stable and intact. They persist after 7 days. They contain all the growth factors that we're looking for, and there's a good scaffold that's there. So the first study, there were a bunch of case studies that were done in venous leg, which is how I built the clinical trial that I looked at. So this is how it's put on venous leg, and there were 21 patients with 12 venous leg ulcers, with 17 treated ulcers, 9 non-VLU patients, and then this is what it looks like. They had complete closure in about 65% of the venous legs. They also looked at what responder rates were. Again, the FDA doesn't really care about responder rates. They only care about closure rates. But if you go from something which is, in 12 weeks you look at it and it goes down by 90%, even though it's not closed, there's some value to that as well. But the mean time to closure was about 7 weeks with a 6-week median, and it required about two applications for patients. In the non-VLU patients, which is what I'm going to be taking a look at, there was about a 44% closure. So here's some cases that are done in VLUs. Here's an 85-year-old with a 1-year history of VLU, had 3 applications that were closed. And this happens, these close super, super, super fast, very fast. Now, they're not great for very deep wounds. But for superficial wounds, you'll be surprised. I mean, some of these closed in a week to 2 weeks, where they've been open for a year to 2 years. This is my paper, which was published at the end of last year, so it was before, it was right after the conference last year. We looked at 25 patients who, again, in this study, we had 18 patients who passed the screening. 8 healed, 6 didn't heal, and 4 of them were removed from the trial. So we had 14 patients in the cohort. It was an open label trial here just for a proof of concept. 8 out of the patients closed within 12 weeks. So it was 57% of patients closed their chronic DFUs with platelet-rich fiber matrix and standard of care. Standard of care, as with most cases here, will be an offloading boot, saline moistened gel, and frequent debridements. Along the entire cohort, 10 patients, so 71 patients had greater than, so this is how rapid it was, greater than 50% wound reduction by 4 weeks. So, which is fantastic, because we're always looking for improvement of over 50% within 4 weeks. 4 patients had greater than 50% wound reduction by week 12. This was the smaller group in that cohort. So what's the benefit of using this over something that comes in a box, right? We have lots of things that come in boxes. Cost, it's the patient's own blood. It doesn't really cost anything. Availability, we have plenty of blood. You don't really get that much cross-reactivity from collagen, but it's rare, but it's possible. And there are lots of patients want to use their own body to be able to heal themselves. So there's this mental thing that they say, well, I have everything in me to be able to heal myself, so why don't I go ahead and do it? So the parenthetical on this is if somebody's very old, right? And by very old, I mean over 40, right? Their growth factors, it's like a roller coaster. You're on the down end, right? So like once you hit 40, it just kind of like, just kind of like drops. Now, it doesn't drop down to 0. It's still better than not, because we're concentrating the platelets and concentrating their growth factors. But you should know that it's not as good. And as we get older, our growth factors just are not as active as they are beforehand. And that was the end on this. But what I will tell you is that if you are looking for something which is biologically active, you can do these things in the office. It's just a blood draw, and you draw the blood. You go in and see another patient. You come in, you pull out the PRP, which is after 6 minutes. You can have prepared the wound in that time, gone out to see somebody, have it spun down in 25 minutes, and then apply it in the office. This can also be done in the operating room. I usually don't plan on having a second and third application, but they're able to do that. You can make as many as you want, right? There's just you can spin 4 vials at the same time, so it's pretty. You can get a pretty large matrix itself. And if it's something that you're interested in, it's commercially available. And if you want to know some more information, you're more than welcome to talk about with me afterwards. Thanks again. I appreciate the committee and Dr. Axman and Dr. Truppel and everyone else for inviting me again. Much appreciated. Thank you very much, and hope you have a great day.